So I'm Gill Richardson. I am a chair of the Wales Centre, a trustee of the Wales Centre for International Affairs. I have chaired the NHS group, which implemented the International Health Charter in the past, and I'm a consultant in public health with Public Health Wales. And I'm so pleased to be able to present to you our panel. And we have here Tina Fahm, who is an expert in governance, risk and compliance, and she's worked in various industry sectors, institutions and parliaments, with over 30 years' experience in helping clients to have good governance and assurance frameworks and to manage risk. And her work supports private equity and a range of investments across Africa. And she has been a lay governor at the London School of Economics since 2010 and has served as the counsel and chair of the audit committee from 2014 to 17. Central to her engagement has been support for the school's equalities agenda and for its work on widening participation. I'm also delighted to welcome our Chief Nursing Officer today, Sue Tranka. And she has been Chief Nursing Officer since the summer of 2021. She's formerly been the Deputy Chief Nursing Officer for Patient Safety and Innovation in NHS England, and she has held the Director of Infection Prevention and Control, leading a national team in response to supporting guidance and implementation and mobilisation of the NHS services, looking particularly at transmission of COVID in hospital settings. So she has many years of experience in the NHS in all kinds of roles and has a passion for patient safety and quality improvement. She's also led the critical care outreach team in a North London hospital. And she also has an interest in, just get the second page. She has an interest academically. She's an honorary visiting professor at the University of Surrey, and she was listed as the Health Service Journal's one of their 50 most influential people in health from a Black, Asian and minority ethnic background, and is an awardee of the Fellowship of the Queen's Nursing Institute. And then we have my good friend Kelechi, who is Director of Public Health in Cwmtaf Health Board, and he is also the Caldecott Guardian there, and he is from a medical degree in Nigeria and has worked in general medicine and infectious diseases, and also has an MSc in tropical medicine and international health. And he has completed that distinction with the London School of Hygiene and Tropical Medicine and won the Frederick Murgatroyd Prize for Excellence. So we're just delighted to have this panel with us today. And first of all, I'm going to invite them to give their thoughts and reflections on a question we have set them before. Empathy in global health. What is the future? And how can we enable this to happen?
Thank you very much, and I'm delighted to be here. Perhaps in the introduction it would have been helpful to state that my involvement here is as independent chair of Hub Cymru Africa. So being here and getting to meet you all is really part of understanding what that role entails and how we at Hub Cymru Africa can serve you better. So turning to the question for this session, as we've heard today, empathy is defined as the ability to understand and share feelings of another. It is the capacity to put oneself in another's shoes and to feel what that person is going through and share their emotions and feelings. Within a health context and from a personal perspective, empathy extends beyond clinical diagnosis and treatment. It takes on a connection between body, mind, and spirit, and touches our collective humanity, one human being to another. It is our connector. The subject of the role of empathy within healthcare is multifaceted and riddled with intersectionality and complexity. The World Health Organization, for example, estimates that 400 million people still do not have access to essential health services, such as drugs and vaccines. Globally, there are huge health inequalities, both between and within countries. For example, in 2015, the average life expectancy in the UK was 81.2 years, compared with Sierra Leone, which had the lowest at 50.1 years. I know that that data has improved somewhat since, with the life expectancy in Sierra Leone being around 56 years now. But to address these issues around empathy head on, we need to be comfortable talking about the uncomfortable. We've now come to the end of the day. What will happen next? Do we go back to the way we were and what we were doing? Have we been challenged sufficiently to act and do something differently? There are both national challenges and global challenges. From a national perspective, we know the NHS does excellent work, often under extreme conditions. But from time to time, we come across instances when things go badly wrong. These are instances that are devoid of empathy. Think about Winterbourne View Hospital, for example, or Mid Staffordshire NHS Trust, or the recent report about infant deaths and maternity services. What were the other staff doing when these failings occurred? What were the leaders looking at? What data did the board consider? Did they ever put themselves in the shoes of patients or the service users that they were there to serve? Looking at issues of empathy more closely and from a different perspective, we find that issues of racial discrimination persist within our health services here in the UK. For example, in 2020, the Health Services Journal reported increasing experiences of BME staff from bullying, harassment, or abuse from patients, relatives, the public, and their own colleagues. We hear from unions and membership organisations of the overrepresentation of BME staff in disciplinary hearings. During the COVID pandemic, we saw a disproportionate percentage of fatalities coming from BME communities, something that I hope the inquiry into the government's handling of the pandemic will provide more insights and answers on. If we turn to global challenges, a recent report published by the International Development Committee on racism in the aid sector, published on the 23rd of June of this year, makes for uncomfortable reading. It sought to examine racist and paternalistic attitudes in the aid sector, specifically regarding diversity, equity, and inclusion in staffing, resulting in a form of structural and institutional racism in the sector. The question is, there is a problem of discrimination within the international development /aid sector. And the question remains for us in this room, are we part of the problem or will we be part of the solution? interestingly, the COVID-19 pandemic presented an opportunity to challenge some of these structural and institutional issues, as many aid organisations had to quickly shift their operating models, relying more heavily on local actors who could maintain access to local populations. This gave impetus to conversations about locally led development, but it's too early to see if that will lead to a long-term shift in decision-making and power or increased direct funding to local actors. One of the principles of locally led development is that it should work towards a scenario where a country is no longer reliant on international aid. The IDC, in their report, recommended that the aid community should ensure that country programmes clearly outline a responsible and locally led exit strategy. This is what I consider to be an empathetic approach to international development, but I fear we are still some way from attracting it. From a personal perspective, 20 years ago, I served as a lay assessor at the General Medical Council. I was part of a newly formed fitness to practice division dealing with doctors who had been struck off the register following a complaint. According to the GMC, the most common issues complained about were treatment, firstly, and secondly, communication. Surprisingly, for doctors who are so bright and, taught in terms of clinical skills, little regard was given to the interpersonal. And what I learned from that role was that very often the diagnosis is the diagnosis. What makes a real difference is the way it's communicated and that interpersonal interaction with the clinician. But like most people, and I consider myself to be values-driven and fair, I went into that role with the belief that doctors who had been struck off the register should be removed permanently. But I was wrong. Coming from a background in audit, my understanding of such matters was that one was either compliant or non-compliant, black or white. There was no middle ground. But it was at the GMC that I learnt how to show empathy and compassion within a professional context. That with the right support, the right mentoring, doctors could be reinstated onto the register and resume their careers and their lives. And that changed my outlook on professional development forever. Up until then, if I was ever involved in a disciplinary hearing, a person would exit an organisation never to be seen again. And I actually think that in some cases that can be a cruel way of dealing with human beings. But the point I would like to emphasise here is that none of us are born empathetic, and it doesn't happen by magic. It's a skill, and it's a skill that to be effective needs to be a conscious a constant part of our consciousness. I have often used a quote from a Scottish psychiatrist, Ronald Lang, who wrote extensively on mental illness. You may have heard the quote. And it goes like this: "The range of what we think and do is limited by what we fail to notice. And because we fail to notice that we fail to notice, there is little we can do to change until we notice how failing to notice shapes our thoughts." So what are we failing to notice? I invite you to reflect on those words within the frame of empathy and in ways that will challenge any future lapses into willful blindness. So what about the future? If we want a more empathetic world, then we need to drive the change that we want to see, starting from the interpersonal to the global. We need to make empathy a reality through our words and deeds and thoughts. To start, it's about you, it's about us, it's about Wales and beyond. And believe me, the time is now. Thank you.
Thank you so much, Tina, and apologies for omitting the absolute obvious, our new chair. On to Sue.
Thank you very much. Prananda Paub, Adios. Thank you and good afternoon to everyone, and thank you for inviting me to participate in this panel discussion regarding empathy in global health. The theme this year resonates on so many levels, and even more so for today's leaders, I think, given our growing international workforce context, not only in Wales, but across the globe. I think the difficulties that you see experienced, and you will have experienced yourself throughout the pandemic, and its continued effects, is what I'm really interested in addressing, in thinking about, and doing something different for the future. The definition of empathy has been discussed enough today, I'm pretty certain, and we've just heard it a moment ago. So I'm not going to go into that, but I am going to draw out three things: kindness, compassion, and respect for fellow human beings, irrespective of where you hail from, what you do for a living, and who you are. Those three things, I think, are the absolute cornerstones of empathy. As a CNO, and that's Chief Nursing Officer, as the CNO, I uphold the values of my profession and the NHS. And my professional code clearly states that nurses and midwives have a duty to be empathetic, compassionate, and kind. Job done, hey? The code says it. But you and I know that's not the reality. That's not the reality in a complex and complicated system. That's not the reality where workers come together on a daily basis, caring for patients in a very complicated, pressured system. Empathy is the first thing that will go. For me, I think it's not just a duty, but particularly as a nurse, I believe we need to be able to put ourselves in another person's shoes, in another person's situation, and look at their condition, what they're experiencing, look at that through their lens, through their perspectives, through their emotions, through their reactions, and truly share in those emotions and feelings. Only then, I think, we can be in a position to determine the treatment and care required to meet those specific individual needs. And I'm really clear about good quality provision of care. It should be given to all patients, all of our patients. That is the fundamental basis on which care is predicated to ensure that we improve the outcomes. It's equity. Without empathy and equity in healthcare, that goal cannot and will not be achieved. Research has shown us that both empathy and compassion are associated with better advances and adherence when we see things like medication compliance, fewer mistakes in healthcare, better patient satisfaction, better performing teams. It's associated with happiness. It's associated with good performance. It's associated with better outputs and outcomes. The need for empathy, therefore, can impact, I think, on the whole patient but staff experience as well. Often we sit here talking about the patient, and whilst I'm really clear about patients first, I want to take a step back and say workforce first. Our staff that turn up every single day, that turn up and show up in the face of adversity, that turn up and show up as their whole selves when they're not fully welcomed into the workplace. I say our workforce first. And it's their experience that will determine the patient experience. Unhappy workforce make for unhappy patients. Unhappy workforce make for poor outcomes in patients. That evidence is there, that research is clear. So without empathy for your workforce first, we will not improve the patient outcome. I'm sure we can all think of a time when we, as the patient, through a GP, through a practitioner you've met, a consultation you've had, with a health professional that was not engaging with you for whatever reason, how did that feel? Stop for a moment. Think back to that time. How did you feel? What did that leave you with? What was that thing in your gut that you felt when you walked away? That is what our workforce feel on a daily basis when they turn up, whether they're global workforce, whether they are the global majority nurses, because I'm no longer calling the nurses black and ethnic minority nurses. We are not a minority. We are the global majority. So when they turn up into the workforce and they are treated in the manner in which they're treated, that thing you feel when you're with your practitioner who doesn't listen to you and doesn't take you seriously is what the workforce deal with every single day of their working lives. Empathy certainly helps build trusting relationships. It builds the confidence. It helps the nursing workforce in Wales, to manage the significant pressures and challenges that we are dealing with, the enormities of the future when we look ahead and we are uncertain how we will come to work tomorrow, how we will turn up in the face of a looming industrial action, what we will do for our patients from day to day. Empathy is the thing for our workforce that will help us manage this in the next phase. Our workforce is becoming much more diverse. You'll be familiar with this. We are recruiting globally, constantly, to meet the demands of our country currently. While we welcome the populations and we welcome people from across the globe, are we doing enough to serve those diverse communities? Are we doing enough to serve the diverse populations? And do we see each other and look at each other with the empathy that it requires? Intercultural empathy is one of the key skills needed to develop a real understanding across our challenging and changing cultures. And that, I believe, is our challenge today as we look to continue to grow our global workforce and operate in a more virtual world. Operating across cultures is not easy. It is absolutely a difficult thing. It is a challenging thing, and we must face that first. But to operate across increased complexity and overlay that in what is our current world, virtual, a virtual context. You and I connect when we meet each other, when I look at you, when I see you, when I get your energy and you get mine, we connect. The connectors are there. When in a virtual world and a screen is up, how do I connect interculturally? How do I connect with the workforce or a patient on the other side of a screen? I think this implies for us future cross-cultural difficulties and future misunderstandings, even more so than we experience right now. We have to think about these challenges, and we have to work out what we do to support a very different and changing world. It doesn't matter what background you are from or where in the world you live and practice. Empathy, I think, is the fundamental ingredient that binds us as a nursing and midwifery profession and as a humanity to give the best care that we can by listening, understanding individual patient needs, individual staff needs, and then putting ourselves in their shoes. I launched some priorities earlier this year, which I've spoken about at the Wales Africa conference before, and I won't go into them. But underpinning all of those priorities is one key thing: kindness. I absolutely believe that. Kindness. No matter what position you hold, I hold the most senior role, the most senior nurse leader in Wales. That does not mean I can be devoid of empathy, kindness, and compassion. the tone that you set at the top is what matters for our profession. And my priorities have that thread through all of them. I guess I want to say that whilst we embed the values I just spoke about, we can't forget of some of the really difficult things we've been through, the disparities we have seen, how things have panned out differently for me, for you, for you. We have to talk about that, but we have to talk about it through the right lens, I think. Look at it through the right lens and talk about it with actions. That, for me, is really important. In the nursing context, I'm really clear that we should be embedding at all stages and areas of nursing, we should be embedding these values. They need to be incorporated within the practice. We need to think about them in the basic form of training, in how we mentor, how we offer peer support, and how we move forward. The challenge for me is empathy is not a new thing. It's been here a long, long time, but it is the new necessity. It is the new normal. And so the challenge today to you, to me, and to my nursing workforce is what will we do differently going forward as we understand empathy in this context. Thank you. Yeah.
Thank you very much, Sue. And Professor Nnoaham, Kelechi, do you want to share with us?
Yes, thank you. I feel like I've done a bit of talking in the course of the day, so I'm not going to repeat any of the wonderful themes that Tina and Sue have already explored. About 22 years ago, probably when that young lady over there was born, I finished my role as in my housemanship, a young doctor in Lagos, Nigeria, where I went to medical school. And every graduate in Nigeria has to do 1 year of National Youth Service. So if you're a doctor, you get thrown somewhere where oftentimes you are pretty much the only doctor serving a particular community. So I got sent to northern Nigeria in a state called Bauchi State, in a community called Dambam. Now, in this community, they only had one cottage hospital. And we're talking about a community of not fewer than 500,000 people. And they only had one cottage hospital. So, and I remember the day I arrived in Dambam, after several miles of travel from Lagos up to the northeast of Nigeria. And they had a convoy of vehicles waiting for me, sent by the local government chairman. Wow. It was like, and don't forget, this greenhorn medical doctor, finished medical school, did 1 year of housemanship. So didn't have surgical skills. It was essentially basic surgical skills. And all of a sudden, I see this convoy of vehicles waiting for me, like an important dignitary. So I said, what have I got myself into? Well, anyway, we got there. I said, where's the hospital here? And they took me to the little cottage hospital. And I said, well, where are the doctors and the nurses? I mean, I was trying it on because I kind of knew there wasn't going to be any doctor. But nurses, there was not a single nurse. So all they had was 2 voluntary healthcare workers. And they said, these are your nurses, doctor. Sort us out. So, fascinating, okay? And it was the experience, it was the 15-month experience, because it was meant to be 1 year, but I added another 3 months because I absolutely loved it. It changed my life. And that was where my journey into global health and public health really, really started. But the reason I remember that experience was that I remember asking, where is the pharmacy? They didn't have any pharmacy. So I would have patients that would come to me, and I would make my diagnosis and realize they didn't have any access to any pharmacy. So where in the world are they going to get the medications that I'm prescribing? So I found myself having to get into the bus after prescribing to my patients, get into the bus and travel to the nearest town, which was several miles away, to get their medications with my money and come back and give it to them. So I approached the chairman of the local authority and said, I want to set up a drug revolving fund. The idea of a drug revolving fund I learned in my 5th year in medical school. If you work in a deprived setting, you can set up a drug revolving fund. And what it was, it gave me a little seed money. I set up a little pharmacy, and then I can prescribe and take a little money from the patient so they can pay for it at a subsidized rate, and I essentially plow it back into. And that was how we set up a drug revolving fund that served that community in the 15 months that I was there. What brought that to my mind? It was the presentation that Ian did earlier and raised that excellent point about what is it, somebody posing the question, what is it that an older doctor who works in a resource-rich setting, what can you teach a doctor who works in an incredibly resource-poor setting? Good question. I hope the answer is there's a lot you can teach them. But empathy means that you must have the humility to know that there's a lot you can learn from them, because it does something to you when you have the practical experience of working in a resource-poor setting. And here was me, 2003. I came to the UK for the first time. I was working in the Hospital for Tropical Diseases in Mortimer Street in London. I can still remember the first time we saw a malaria case in the Hospital for Tropical Diseases. I was excited. I'm thinking, this is what you live every day. You see 10 cases. But my complete shift of mindset, this is incredibly resource rich. But you see, I had something that I brought to the table because I lived 15 months and more, setting up a drug revolving fund in an incredibly deprived community. Why am I talking about this? This is about empathy, that there is mutuality in the value, that there's something we can take to low to middle income countries when we're setting up partnerships and we're going from here. There's something we can give them, but we need to have the humility to understand that there is something Sue and myself in the NHS can learn from people who come from there. They have rich experience of, and I think when Kerry did her presentation on antimicrobial stewardship, it's an excellent thing, wonderful example. Here's this medication that these guys exactly know how to use, and that's something we can learn from. So for me, that particular question, Ian, summarized for me the key thing I want to take away from here. It is that mutuality of value. There's value that we can take back to low to middle income countries, and there's value we must open ourselves up and have the humility to receive, because they absolutely have something to bring to the table. Thank you.
Thank you very much, Kelechi. So we're going to throw it open now to you. If you have any questions, could you put your hand up, please? And we will find you with a roving mic. Okay, yes, we have some questions. If you'd like to indicate who you'd like to answer your question as well.
Right, I was trying my hardest not to be the first, but okay. So we've talked a lot about empathy, and I was a bit curious about the word empathy. And from what I understand from some of the reading I've done, it's quite, well, you can say it's relatively a new term in itself. Just about 1909, I think it was introduced into use. You talked about the fact that the UK is becoming a lot more multicultural. And we do understand that when we look at the word empathy, especially from one culture to the other, that word seems to be different from one place to the other. Now, maybe my question will be a two-way, in a sense. So number one, how do we conceptualize empathy when we're working from one culture to the other from a global perspective? And when we're looking at working within the UK setting, especially when we have people that come from different cultures where the term empathy might be seen as a weakness of some sort. Say you're trying to pity people, or you're trying to look down on people by trying to empathize with them. How do we practically instill this skill of people being able to develop empathy? Because we can easily assume that if we just say the word empathy, everyone can understand what we mean or can be able to practice empathy. So I guess that's one question or two questions, I'm not sure. But yeah, that's my question.
So open to the panel. Who would like to begin?
I could start, if that's all right, and I can take it back to the to my context, which is nursing and midwifery. So we have something like 38,000 nurses on the register, the nursing and midwifery register in Wales. 25,000 or so work with us in Wales. The rest work elsewhere, but they have Welsh addresses. 8% of that 25,000 are made up of multicultural, so the global majority nurses. And one of the things that we see constantly within the nursing and midwifery context is a lack of cultural awareness. So I hear constantly, well, the Filipino nurses have been here in this country for 20 years. And I've said this before, so you may have heard me say this. Let's celebrate them. So I said, great, let's celebrate them. So how senior have they made it? 20 years, they should all be at senior levels, right? No, they're all at the most junior level in the nursing world. So I ask why. They say, well, they don't really put their heads up, do they? They're really quiet and soft and kind and gentle. And so you ask a Filipino nurse, well, why don't you? Why haven't you progressed? And they say, well, I've lived in a colonial context my whole life. And now I'm thrown into this culture. I'm supposed to keep my head down, aren't I? And for 20 years, they've kept their head down. So I don't think anyone has taught cultural awareness in the way in which it's perceived by other people, in the way in which cultural awareness, to me, I come from South Africa. I've lived through colonialism, and I've lived in a post-colonial country. But I've experienced it very differently to somebody else who's lived in a post-colonial country. So cultural awareness, cultural training, cultural understanding is the key here to unlock the rest of the things we talk about, how kindness is experienced, how empathy is experienced. I don't think we do enough of that. We almost have an expectation that people will come from across the globe, turn up in a Welsh culture or in a UK context, and just operate in the way in which is expected of them. And if they don't, then we chalk it down to culture and go, it's that difficult, tough thing called culture that we can't address, and so we leave it. So that's my view of it, and I think we need to teach far more cultural awareness. It needs to be on curriculums, it needs to be within undergrad education, it needs to be in postgrad education. It needs to be something that is discussed so that we can unlock those other things. I hope that helps.
Any other additions?
Yes, if I may add, I think you partly answered the question yourself. And that is the challenge of empathy. I like the term in social care of person-centeredness. I spoke about it being human to human. So whatever context we find ourselves with others, that person-centeredness is how we engage and how we reach out. And I think that, as Sue has said, there is a continuous learning element. You know, we think we know. Because we have equality and diversity policies, someone has thought it out for us. But actually, it's what we do every day. It's how we live. It's how we engage. And I think it's a muscle that we need to build up, because it's under times of stress that empathy goes. And, you know, as we've seen within the health service itself, this is where the failings occur and people suffer. I hope that answers your question.
And lastly?
Again, I just, you know, I remember very quickly when I first of all came from Nigeria to London, and I was doing my master's in London School of Hygiene and Tropical Medicine. I used to have a supervisor who, in conversation with him, I would always say, sir, sir, sir. And one day, Peter was his name, Peter Brambleby, a lovely man. He said to me, Kelechi, you really make me incredibly uncomfortable when you call me sir. And can you stop calling me sir, referring to me by sir? And when I look back at it now, I laugh, because if you grow up in Nigeria, that's how we refer to our professors. You don't look at your professor and say, Peter. You don't do that. I mean, I remember attending an interview shortly after, and somebody said, you must look into their eyes. You must look into their eyes. What is all this looking into their eyes? We don't look into the eyes of people that we refer to as elders, people we respect. Our culture says you keep your eyes down. That cultural awareness, that empathy that allows Peter now to understand that actually, let Kelechi do that. That's the way, that's the culture he's comfortable with. Let him do that. To force him out of that is to actually demonstrate a lack of empathy. And I think that's what we've got to begin to challenge. That cultural awareness, I think, is really, really important. We've got to create a condition that recognizes the backgrounds that people come from, especially in a time when we are, I was saying to Sue earlier, the Welsh government is recruiting more and more health workers from low to middle income countries. The number of Nigerian doctors that are registering every day with the General Medical Council, we've got to create an environment that is absolutely culturally aware of their context and their backgrounds. So absolutely right question. And the other thing I just wanted to add was you used the word pity, and I think you were absolutely right that empathy is not sympathy. And that's one of the things. This isn't about pitying people, it's about putting yourself in the shoes of other people, and it doesn't have to be sympathy at all. Thank you.
Yeah, really important. Thank you. Angela, and then Catherine. Catherine on the way. Yes.
Thank you. Hi, I'm Catherine Thomas, and I've enjoyed what you've been saying so much. It's really got me thinking. And my experience of, you talked a lot about empathy between the clinician or the service and the service user or the patient. But it's made me think about empathy between health workers. I mean, I've sat in as was a GP for a long time, and I've sat in with people doing a similar job in Ethiopia, Zambia, Cuba, Lesotho, and sitting there with somebody doing what I am familiar with and doing it really well, and then thinking, well, they're doing it with far less resource and support and access to education and training than I have. So that I kind of feel the respect that you talked about, Sue, which I think is a really important part of empathy, and that respect, and that to come back then to Wales, and we have a government that values empathy more than the UK government perhaps at the moment, which doesn't seem to value or prioritise empathy. So we have that, but we also, as you pointed out, we are employing an awful lot of our workforce from countries that need them much more than we do. So it's great that health workers can move, and I would fully support that. But what do you think in Wales we are doing to pay back for what we are exploiting? What can we do to pay back? And have you seen, since you've been here, Sue, have you seen any practical examples of how we're paying back in terms of empathy with health workers, and a lot of people here are health workers, with our colleagues who are doing similar things in much greater pressure than we are? What's happening and what's going to happen?
Thank you, Kat. Yes, so great question. When I set my priorities, I was really clear workforce is our biggest global challenge. Absolutely, for healthcare workers across the globe. So it's not just nurses and midwives. And when I talked to the service, I asked, what shall we do? How shall we fix this? Because that's how I do things. I ask the people that are experiencing the challenges. And they said, we should recruit people from abroad. And I said, great. So how are you going to look after them? B, how are you going to help them to progress? They can't just come here and be a number for you, so it takes the burden off. And lastly, what will we do for reciprocity? What is the reciprocal relationship with the countries from which we take workers? What will we give back? And everybody went, God, what is she talking about? We just want the nurses. And actually, we went on to develop the strategy. So the first, there are two things for me, Kat. One is Swansea University. We've just been working with them and asked them to take on international students from the countries that we recruit from that are in their second or third year of nursing or midwifery. That we complete the last year for them here of training at our cost, and we give them a postgraduate training on top of that at our cost. And then the reciprocal arrangement with that is that they will continue to work for us in Wales for a year maybe, and then we give them an advanced skill and qualification that they have to take back home to them. where they can go and run their nurse-led clinics, put the experience back into the service, whilst sharing with us their experience whilst they're here. So that is just about to take off. It's this March, I think, March coming. That's the first, and I said that when I first came in, that we would do that. The second thing we've done is, I don't know if any of you know, when we recruit from abroad, we bring, so whether you're a doctor of nursing, a PhD in anything else, whether you're a professor in your country, when you come to the UK, you start at the lowest possible banding. So we wipe clean the slate of all your experience. We assume you know nothing. We treat you like you know nothing. And we start teaching you the basics again, which is absolutely preposterous, I think. Having come from South Africa with a huge amount of experience behind my belt, I could do and could function at a very, very high level of practitioner status. And I came here and had to learn to redo everything again. And I did it because that's the way. We're no longer doing that. We are now going to, if we recruit from countries where you are a senior nurse, you will come here and you will start at an equivalent of a senior nurse with a senior salary, with an absolute recognition of your skills, and we will change the workforce. It's not easy. It's a real battle, and it's going to be taken up by some, and some health boards may choose not to have those nurses who come in at a higher level. But I'm all for equity, and for me, that is equitable for the workforce. So that's two ways we are going to give back, I think, to the countries that we recruit from.
Thank you. Any other observations?
Fantastic, thank you, Sue. Absolutely nothing to add to that, but what you said reminded me of a conversation I had with a young lady over there during break. Exactly the same situation with physician assistants, that's what you were telling me. And perhaps that's a conversation to pick up with the CMO at some point. But thank you very much for that. I just wanted to make that connection.
I'm Angela Gorman. I'm a retired NICU nurse from UHW. I'm going to make a plea for the respect and the empathy to be extended beyond the nursing profession, because if this pandemic has taught us nothing, it's only that every single person in the NHS is precious. And I feel, just to give you a graphic example, when I was working in NICU, we had a particularly busy period, and I was the sister in charge of the unit. And it was so busy, I couldn't get a housekeeper, so I went and donned an apron and gloves and everything, and washed a space in the ITU room ready for this baby to come back from theatre. But at the time, the consultant was doing a teaching session for medical students, and I had to ask, excuse me, to get in there with the buckets and the mop. And one of the looks I had from the medical student it was horrendous, and I thought, right, I'll have you. And so I did the cleaning, took everything out, and then I went in front of the consultant, in front of these students. I said to the consultant, oh, Patrick, when you finish your teaching, can I have a word with you to see whether or not we're going to be able to take babies tonight? Because as the sister in charge of this unit, and I saw this student's face drop. And so afterwards he said, what was that all about? And I said, you didn't see what I saw. And I said, the way that, because he thought I was the housekeeper, he treated me differently. And we have to extend this to every single person in the NHS. We're all precious. They're all precious. If they weren't, they wouldn't be there. And as I said, the pandemic has brought this to the fore, really, of how important every single person is. So, yes, with the nursing profession, definitely. When my daughter went into nursing, I said, treat everybody as if they're me, as if they're me, your mother, and you won't go far wrong. But we have to treat everybody as the precious individuals they are. Thank you.
So it's me. Is that for me? Do you want me? Yes. No, absolutely, and I couldn't agree more. I think you said everything that needs to be said. You know, I think, and I've said this earlier, you know, we should treat people with the utter respect and compassion and kindness they deserve, whether they are taking out our bins today, cleaning our floors tomorrow, or delivering our baby the next day. Everyone deserves that respect, and I think it starts with us in this room. I think it starts with us collectively, and if we can set the tone, if we do that with each other, this will translate across the services. It's not an easy thing to do. In professions like medicine and nursing, there's hierarchy, and it's important, and it comes from, you'll know where they're set from religion and other things by background. This hierarchy is important. So, you know, I say be a positive disruptor. Shake the system, shake it, and let's see what falls out, and I'm right there alongside you.
Fantastic, thank you. Okay, I'm going to bring our questions to a close now. Very much, Angela, the NASA old adage, the man with the broom put the man on the moon. Every single person along that chain was important, weren't they? So I'm going to ask our panel just for some closing reflections, and then I'm going to ask our young volunteers to just give their closing reflections as well. So Tina.
Thank you. So at the start of the conference today, we were invited to engage in ways that would challenge and inspire us. I think we've heard a lot to set us on that path. But I sincerely believe that at the end of the day, whether we engage empathetically or not is entirely up to us. And I hope that we've heard enough today that will motivate us to do that. Thank you.
Thank you. I think we certainly have. Thank you. Sue.
Oh gosh, I feel like I've spoken so much. What would I say? So let me share something from a village in Africa that most of you will be familiar with. We've spoken enough about empathy, but I'm going to say that together, as we sit in this room, you know, if you want to go far, you know, go alone. If you want to go fast, go alone, and if you want to go far, go together. And that's the collectiveness I often will talk about, and the collaboration that I'm seeking. And I think we can and we should be the ones that start to change the world and change the narrative and change the discussion. So yeah, I'm going to leave it with you, or I always leave a challenge in the room, and Kat knows me for that. So that's your challenge. What will you do differently? And I know what I will do differently as I step away.
Thank you, Sue. Kelechi.
Thank you. My favorite author is a Nigerian lady called Chimamanda Ngozi Adichie, whom many of you will know. She once gave a TED talk that was titled The Danger of a Single Story. And I want to charge everyone, in a sense, with that. Let's all go away from here always asking, what is the bigger story? And finally, I think it was Margaret Mead who once said, never doubt that all it takes to change the world is a small group of people. Let us be that small group of people who live here today and go out and give kindness and empathy to the world. Thank you.
Thank you. So I thought it was important to involve our youngest people because we are here as a result of that gentleman on top of the door. If you just take a look, he's been observing the proceedings the whole day with approval. He is David Davis, who was an MP and then a Lord, and he set up this amazing building, and he crowdfunded, if you like, for it, and used his own personal resources as well, to set up the League of Nations in Wales, to be the precursor to the United Nations, so to bring peace to the world, and also health. And he set up an organisation to address the ravages of TB in Wales. And as you know, TB is now controlled largely in Wales, although our pharmacist might say there are still pockets. But so we are here as a result of the vision of somebody that they had, that there would be generations that came after them that would have a heart for justice and peace and health. So, so it's very fitting to ask our younger generation for their comments.
Do I have to stand up?
It's up to you. Yes.
Hi, everyone.
Hi.
I was asked to come up with a sentence of what I just got from the whole session today. And I'll say that empathy is paramount in making healthcare services holistic and effective. It is a skill of kindness, compassion, and respect that can only be developed via actively understanding and connecting with our fellow humans at an individual level.
Thank you very much. And then our second speaker. I thought you were the second, yeah. you were one of the two men left standing. So over to you.
Good to know I'm one of the youngest, hey? Feels so wrong. Right, I think we've talked about empathy, and I think Cheryl pretty much nailed everything. But I think it's the importance of knowing that it's a skill. And I like the fact that that was emphasized as well. That means we can all learn it. There are no excuses for it. We can all get better at it. And we've talked about the importance of it to the healthcare we deliver and the people we work with. Yeah.
Thank you. Thank you, Joseph. Okay, so I'm going to hand back over to Beth. Is that the end? Or is Tina closing for us? Yeah, okay. Closing remarks from the chair, I think, are called for.
I think I'll stand up for this. Well, first of all, ladies and gentlemen, I won't keep you further, but I think it is important to reach out to Professor Kelechi Nnoaham. I'm very proud to be working with you, Kelechi, as part of Hub Cymru Africa. I'm very pleased to meet you, Sue, for the first time, and Gill also. But it's really is about Hub Cymru Africa and the way we serve you as a partnership. I'm grateful to our team here, led by Beth, Kathy, Head, and some of the others. I apologise if I haven't mentioned your name, but there's been a lot of planning that's gone into this event, and I think it's gone smoothly and has been a great success. So if we could give a round of applause to the team, that would be much appreciated. So in true African style, it remains to thank you once again and wish you safe journey back to your respective destinations. Until next time. Thank you.
Thank you.